Okay, so now we'll be talking about PCI indications. So it's recommended over fibrinolysis at PCI capable centers in patients with STEMI less than 12 hours of symptom onset. Door to balloon time, ideally less than 60 minutes. And PCI is recommended regardless of time from onset for cardiogenic shock, malignant arrhythmias, things like VT, VF, and persistent ST elevation and or chest pain. Late percutaneous intervention that's greater than 2 days or post-event is generally not indicated for stable patients. And if PCI is delayed greater than 2 hours, there are worse outcomes, and you can consider fibrinolysis at that time. PCI strategies, the ACS is seen more benefit in radial greater than femoral. Stents have seen more benefit, and drug-eluting stents greater than bare metal stents. And in patients with STEMI without cardiogenic shock, complete revascularization strategy, so that's the culprit lesion plus possibly non-culprit lesions that require stenting has shown decreased risk of cardiovascular death and MI at 3 years. And you can read that at New England Journal of Medicine, the complete trial. STEMI with cardiogenic shock. So this patient is presenting with STEMI and signs of cardiogenic shock. Culprit lesion, only PCI has shown decreased risk of death. So it's important to make that distinction, whether patient's in cardiogenic shock or not. And usually the fellow kind of makes that diagnosis of cardiogenic shock or not in patients with STEMI. We have time to quickly talk about CABG. It's preferred in multivessel disease, so 3-vessel disease, left main disease, or 2-vessel disease with proximal LAD stenosis, or patients with EF of less than 50%. And you can read that New England Journal of Medicine 2009, Lancet, and New England Journal of Medicine 2016. And guidelines are also here updated in 2022. Next up, we'll be talking about fibrinolysis, although not usually done at PCI capable centers. And then afterwards, we'll be talking about risk stratification for PCI timing in patients with NSTEMI.